experts, Dr. Mala Chhabla and Professor Piyush Jain. I was just sitting over here and reflecting. First and foremost, our ED, Major General Professor Atul Kotwal, is still stuck in a meeting in the NITI. He has just texted me about 10 minutes back that it seems unlikely that meeting will be over so early. So has asked us to go ahead and has conveyed his best wishes for this important event. I've been thinking that it was about precisely a year back in the month of September last year. And we had the first lecture on snake bite, Dr. Himmatrao Bhaviskar. And since then, we have come a long way. And I must commend, compliment, and pay my regards to Dr. Sangeeta Sharma and President Delhi Society for Promotion of Rational Use of Drug, that she is so passionate about this promotion of rational prescribing that she made sure that there is no discontinuity. And that's why we are here. As Siddhi mentioned, my colleague, young colleague, we are still thinking that what should be the benchmark to issue the certificate of appreciation, not necessarily that 24 out of 24, but we'll work out some criteria. Perhaps those who attend, say, 10 lectures out of 12 can be considered. But attending means that you have attended, you have undertaken the pre-lecture test and the post. And that gives some kind of objective, say, bearing to us that where do we stand and how far we have been successful. All these topics, even last year or this year, we have always chosen a contemporary topic which is relevant and which appeals to everybody, whether somebody is working in a peripheral setup in a primary health center or in a small dispensary or in the clinic in a remote corner of the country, or working in a tertiary care institution at the best of the places, irrespective of private or public. And we all know monsoon season is still not over. It is major portion of Delhi and other parts of the country, they continue to receive the rains. And the problem of dengue is very relevant. And in this context, I was reflecting back that this was perhaps in 1996. I was posted working at a place in Faridabad in the city. And when first time hemorrhagic fever, shock syndrome struck us. And initially for a couple of days, couple of weeks, few of us may recall, there was a sense of panic, paralysis, and over-treatment, over-infusion of the platelets. And since then, we have come a long way. But still, it becomes necessary that we refresh our knowledge and we remain relevant and contextual, that whatever the things have happened, because since then, a lot of scientific impact evidence during last 25 to 30 years have gathered, and which has defined the practices. But at the same time, in the periphery, we still feel that whenever we interact with the people, they always say, I mean, if I can use that term in Hindi, कि डेंगू हो गया, अब जल्दी से इसको प्लेटलेट चढ़ाना है, ब्लड चढ़ाना है. So in this context only this topic has been chosen. I will not go into much into the statistics, but broadly speaking, this is a global problem. Wherever you travel, there are few countries which have eradicated malaria, but dengue they are still struggling to contain it. And without much going into those details, since we have got the expert, initially Professor Sangeeta Sharma will talk about that why we should stick to the standard treatment guidelines. Subsequently, we have got the two eminent experts who will talk on the diagnostic criteria, certain pitfalls, what are the certain basics, and then Professor Piyush Jain will talk about certain do's, certain don'ts, and how the case has to be managed, a clinical case has to be managed in a given clinical setting at different times. So I will stop over here. We look forward to active participation in the coming months as well. And it goes a long way in improving the rational prescribing, and which will help us in getting better health outcomes, and our patients will be feeling better within given limited resource setting. And once again, thanks very much to the experts and Professor Sangeeta Sharma and my two young colleagues over here and our IT colleague. Thank you.
Thank you, Dr. Srivastav, for continued support for doing this program for the second year now. It was a very, very delightful experience for us as well, and it gave a lot of sense of satisfaction that we've been able to do, reach out to so many people despite our limitations. And I think all the participants will also agree such a coverage otherwise would not have been possible, without this support. And online sessions have come to our rescue here, in fact. So welcome to you all about this series 2 of the standard treatment guideline concept. And Dr. Srivastav has already told you about the need or the priority why this disease is so important for us to address. Usually, in the name of dengue, because the disease has a wide clinical spectrum, and this change or shifting to severe forms is quite quick, and need for platelet transfusion, it creates a lot of sense of panic and anxiety amongst the patients as well as the healthcare workers. So just to introduce the topics and the specifics of the topic, I'll that India is home to 1/3 global population at risk of dengue, and this is one of the most widely spreading mosquito-borne illness of humankind. And over the years, the incidence prevalence has been rising, and it almost has increased 30-fold. And so as to, that this has become a major public health concern throughout the tropical and subtropical regions in the world. And you keep hearing about dengue in the newspaper. Dengue is breaking records. What is behind the surge? And in fact, global warming, some WHO has come out that global warming is pushing near historic highs. And of course, the catchy news in the newspaper creates a lot of anxiety and panic amongst the population. So we know that dengue epidemiology, Dr. Mala Chhabra will be talking about a little bit in detail, but I'm just giving you the overview. The burden of dengue is comparable to the burden of TB and other communicable diseases. So that's the size of the problem. And additional challenges that we face as healthcare providers is that unexpected surges in the cases, so the unexpected cases suddenly coming up, and if we have inadequate health systems, if triaging is not proper, then it can lead to can I annotate here? Okay. Health system of triaging can help us managing these cases appropriately. And over the years, although the overall incidence may be dipping, but it has not been eradicated yet. And if you look at the number of cases, you may find that there is a surge in between as well. So it can happen anytime. So we need to be ready, all the time during this season for any outbreaks here. As I said in the beginning, we need a standardized management of dengue because it has a wide clinical spectrum ranging from asymptomatic cases to mild, moderate, and severe. The severe one are at risk of death, higher mortality because of dengue, hemorrhagic shock. So that is why it is very important to recognize timely recognition, diagnosis of dengue is very important. The progression to severe forms of the disease is very fast, and we don't have any definitive curative medications for dengue. Management, by and large, is supportive only. Although it is a self-limiting illness, but because the progression can happen quickly if we don't identify patients at high risk or those who are having warning signals of a severer form of dengue, we may lose the patient. So if you want to improve the health outcomes, and if you want to reduce the burden on healthcare systems, there is a need for timely, consistent, and evidence-based care here. So as I said, when we keep saying that you need to have dengue here, for that you need to have a clear criteria for diagnosing dengue. We cannot work on presumptive basis here because of the nature of the illness and the progression to severe forms. So we need to be sure what we are dealing with. So, but for that we need a clear criteria. There are lots of tests available. All those need to be utilized optimally. Dr. Mala Chabda will be talking about this. So early diagnosis, if you know that you are dealing with dengue, because otherwise clinical manifestation may not, acute febrile illness could be because of various other reasons as well. If you recognize this diagnosis early, you can take appropriate measures, closely monitor these patients, and intervene and before the disease progresses to severe stages. So for this, clinical early detection and diagnosis is also important. If you can focus on the hydration, recognition of comorbid illness, differential diagnosis. So this needs to be supported by rapid assessment, laboratory access. So, and this is also important from programmatic point of view, that you need clinical incidence data, because then you know that there is an outbreak in the community or a region, so that appropriate measures can be taken to prevent spread of this dengue. Risks, you can standardize management protocol. They help you in risk stratification. In this, what is mild, moderate, severe, what is life-threatening form of the disease, all these things are defined so that you can make out what are you dealing with here. So and accordingly you can mobilize resources for prioritization of care of these patients. Then of course you need optimal treatment to ensure effective and safe treatment, which is evidence-based. Then for prevention of complications, it is very important that we take steps to prevent complication, and medical attention is given to reduce the risk of severe complications. And in this regard, I can, the government also takes the proactive steps. For example, in July last month, Delhi government issued a notification that which is prohibiting sale of painkillers by chemists, because NSAIDs are one of the although you need paracetamol for bringing down fever, but irrational or non-optimal use of these painkillers, overuse of these, can increase the risk of bleeding in these patients. So government had taken a proactive step here to manage this. Then consistency in care, one of the reason panic is created when once the patient starts bleeding. So platelet, many of us do not understand what is the count, which is count of platelet, which is critical. So management may differ in different health facilities because we don't understand this. Although the standard treatment guidelines, they talk about the typical patients, the typical presentation, and how these should be managed, but we should be in a position to understand what are the atypical presentations or people who would need specialized care here also. But by and large, it depends on also the severity of the disease. The same standard has to be followed for the management. Only thing is the referral criteria, which differs, depending on the available infrastructure, manpower, resources for management. You may have to refer these patients to a higher level. When I say referral criteria, it is the referral criteria which is different. I mean, for example, you may have a mild, moderate patient presenting at a tertiary care level right away because that is next to your house, but that doesn't mean that we will give treatment which is warranted for severe dengue just because the patient has landed up in a super specialty hospital, or you will infuse platelet at an early care stage. So consistency is in care is promoted by following the standard protocols. And also, of course, the healthcare professionals also need training, education, so for management of dengue effectively. And I think you can consider this session today as one of the attempt to empower you or refresh your knowledge about management of dengue fever, so that you can upgrade your skills and manage these patients appropriately. Then of course we also need standardized management protocols for monitoring and surveillance. Again, these are very important. You need to follow the definitions, the progression and documentation of these, and so that you can calculate effectively the burden and allocate resources accordingly. Of course, standardized management protocols also help in defining the framework for research and development in this area. One of the most common area where people are working for management of dengue is the vaccines for this prevention of dengue. Then prevention of dengue, vector, how do you control vector in the country? So vaccines, although we don't have a very effective medicines till date, but some of the work is being done on this. The vaccine which is available right now is efficacious and safe in individuals without prior exposure. So since this is endemic, so it's very hard to find this group of patients. But anyway, and then 3 doses are administered. Indian vaccine people are working on this, but still this is under development at this stage. So by and large, it comes back to that we need the treatment is mainly supportive as of now, but we have to work in an integrated manner, which includes vector control, environment, patient care, laboratory diagnosis, social communication, and surveillance of this. So if we do this in a timely manner, perhaps we will be able to tackle this deadly disease and improve patients' outcome. Thank you. We have the guidelines. WHO has produced the National Vector-Borne Disease Control Program. NCDC, they have also developed these guidelines for dengue case management. We have our own standard treatment guidelines where, the dengue is one of the common diseases, so it has been adequately covered. These are evidence-based, updated from time to time. So these are very well aligned with the WHO and the national guidelines for diagnosis. So I think with this, I'll stop. Has Dr. Mala Chabra joined? She is actually in Kerala because of that Nipah virus outbreak. So she has gone to investigate that outbreak in Kerala. So Annapurna, can you check out?
Yes, my ma'am is there.
Namaskar, ma'am.
Oh, okay.
Can you
Good
hear
to see
me?
you.
Yeah.
I know.
I couldn't have missed
Thank
this.
you for joining.
Yes, yes,
I
ma'am.
know you were out in the field.
Yes, ma'am.
Thank you for joining.
Yes, ma'am.
Please carry on.
Can you please
Take the
tell me how to
forward.
share my slides on this? Can somebody help me?
Yeah, just can you see this share button here?
Where, ma'am?
Bottom पे देखिए.
हाँ है. ठीक है.
Share करिए.
Thank you, Sangeeta ma'am. Now I introduce Dr. Mala Chabra ma'am, who will be guiding us on need of management for the dengue diagnostic guidelines. Dr. Mala Chabra is a ND member who of WHO Regional Technical Advisory Group on dog-mediated human rabies in Southeast Asia region 2023, formerly at National Center for Disease Control. She has worked there for more than 17 years, additional director and head zoonosis division and head WHO Collaborating Center for Rabies Epidemiology. She has more than 36 years of experience in teaching, research and administration. She has facilitated more than 200 trainings for international, national, state and district officials on rabies prophylaxis, ID inoculation of ARV, implementation, laboratory diagnosis and prevention and control of rabies. Training of WHO fellows from Southeast Asia region like Bhutan, Nepal, Sri Lanka, etc. and postgraduate students of community medicine and microbiology. She has carried out multicentric study on rabies epidemiology in India for gap analysis and formulation of rabies control program for India as WHO APW from 2004 to 2006, conceptualized and implemented National Rabies Control Program under 12th five-year plan from 2012 to 2017, contributed in National Action Plan Rabies for elimination of dog-mediated rabies. Over to you, ma'am.
Can you please help me to share the slides?
And please share, click the share button.
Yes, I have.
अभी उसमें आप शेयर करने के बाद वो आपका पूरी स्क्रीन दिखा रहा होगा.
No, it
if you
says
have
allow WebEx to share your content. Open.
Yes,
Yes.
ma'am. Hello.
Yes, ma'am.
हाँ, उसमें आपका अगर have you your file open?
Yeah.
वो वाला ओपन जो फाइल है वो क्लिक करिए.
Open file. Okay.
नहीं आपका फाइल अपना प्रेजेंटेशन की फाइल खोल लीजिए मैम.
मैम खोल लिया.
अभी स्क्रीन पे आपको क्या दिख रहा है?
स्क्रीन पे तो अभी मुझे सिर्फ आई कैन ओनली सी द पार्टिसिपेंट्स.
नो आपने शेयर वाला बटन दबाया?
हाँ जी.
हाँ, तो अब आपकी स्क्रीन नजर आ रही होगी विंडो में, पूरे में नहीं.
विंडो में भी नहीं आ रही है. इट जस्ट सेज ओपन सिस्टम प्रेफरेंसेस.
उसमें क्या क्या है आगे?
Nothing. It's just not showing anything.
आप मेरे को फॉरवर्ड कर दो जरा, मैं I'll start.
Okay. I will send you the which email ID, ma'am?
किसी पे भी कर दीजिए, Gmail पे कर दो.
WhatsApp is also fine.
You must be using
WhatsApp.
MacBook. Mala ma'am,
Yeah.
you are
Yes,
you must be
please.
using Mala MacBook, no?
Yes, please.
So you have to, I think, grant the permission for using those your files to be shared with the WebEx. In
How
system
do I do
preference,
that?
you have to do
तो
that.
yes कह दीजिए उसमें yes कहना होगा
कर
आपको
दिया
पहले।
yes ना, I've done the yes thing. I have given the permission.
Next क्या आ रहा है स्क्रीन पे?
Nothing. That's what the problem is. Let me just check once again. Or
Ah.
I'll mail it to you, I think. That's
व्हाट्सएप
what
कर
I'll
दो,
do.
मेल कर दो, जो भी कर दो। I can
I can
start
do.
display from.
Yeah. Just give me a second.
मैम उसपे ना नीचे चली जाइए, उसपे वो कर दीजिए।
क्या करूं?
उसमें मैम आ जाएंगे, जो आपका वो आ रहा है प्राइवेसी में आ रहा है, उसमें दे रहा मैनी ऑप्शन, एक वेबएक्स का वो ऑप्शन आ रहा है, उसको क्लिक नीचे से पहले लॉक अनलॉक करना है और फिर उसको क्लिक करना है।
अच्छा, let me just try that.
नीचे सबसे पहले एक लॉक बना हुआ आ रहा है, जब जस्ट क्लिक दैट लॉक टाइप का थिंग फोटो आ रही होगी, और जस्ट मेल इट टू द मैम।
हाँ, मैं कर रही हूँ, मेल ही कर देती हूँ।
डॉक्टर पीयूष, तब तक आप ट्राई करके देख लो, आपके एंड पे तो कोई प्रॉब्लम नहीं है ना? मैम कर दिया?
हाँ जी मैम, मैंने जीमेल पे आपको मेल कर दिया।
ठीक है। DSPRUD वाला ईमेल पे या मेरे पर्सनल पे किया?
पर्सनल पे मैम।
ओके, अभी अपडेट नहीं हुआ है। आप तब तक मे बी आ जाएगा, इट टेक्स सम टाइम टू।
शर्मा संगीता 2003@gmail.com।
हाँ, आई एम ऑनलाइन हूँ उस पे, पर अभी आया नहीं है। मे बी आप स्टार्ट करोगे। आपकी पिछली वाली प्रेजेंटेशन से अलग है कि नहीं? तो मेरे पास वो है,
सेम है मैम।
सेम है, तो मैं यहाँ से अभी करती हूँ। ठीक है, आई डोंट हैव टू वेट फॉर दैट। ओके, लेट मी ओपन दिस।
So can I start then? थोड़ा सा।
हाँ, आप स्टार्ट कर दीजिए मैम, मैं तब तक।
So good afternoon everyone, and sorry to have kept you all waiting. But at the outset, I will congratulate and thank NHSRC and Disproved for giving me this opportunity on a very, very important topic. And madam knows that I'm not in station, and that is why probably all these issues are coming in. I'm sorry about that, but this was so important that I came back from field to just to talk about dengue testing guidelines and some advances in lab diagnosis, that are much required with ongoing season now, as madam has explained. Next slide, ma'am. That dengue and chikungunya both are very, very important vector-borne diseases. And why should we bother about dengue? Because dengue is expanding. It has gone global. Mosquito and vectors don't spare anyone. They don't need any visa to travel from one place to the other. They are just there and they are spreading the disease. Next slide, please. So it is one of the most rapidly spreading mosquito-borne illness, and there has been 30-fold increase in global incidence in last 5 decades. This is a major public health concern throughout tropical and subtropical region, and about half the world's population lives in these areas which are endemic to dengue. And this is one of the neglected tropical disease, and if managed properly, the mortality will be very less. I'll show you the mortality in my subsequent slide. As a management improves, Dr. Piyush is here, he'll agree with me. If these patients are managed well, we can decrease the mortality to great extent. And it definitely has impact on economy of the country. And if we see the data, which is National Vector-Borne Disease Control data, there are 264 disability adjusted life years per million population per year are lost due to these disease, in addition to 20,000 deaths annually. And it has varying case fatality rate, affecting mainly children and young adults. That is another major problem. Next slide, ma'am. So, some facts just to be aware of, that this is not a new disease. The virus was first isolated in India in 1945, and first evidence of dengue fever was in 1956 in Vellore district of Tamil Nadu. And the first outbreak was in 1963 in Kolkata. And now dengue fever is reported from all states and UTs except Ladakh. And this has, over the years progressed. 1996 saw a major outbreak in Delhi, which was that of hemorrhagic fever with 10,000 odd cases and 423 deaths. Again in 2006, there was another outbreak, which we saw about 12,000 cases and 184 deaths. Again, 2018, 2019, 2020, 2021, except for 20, the cases are increasing every year. And this is National Vector-Borne Disease Control data. Why 2020 there was dip? Because of probably COVID, that everybody was homebound and people were at home, so no need to store water. And otherwise also we kept our doors closed and remained indoor. Probably that is the reason why I have a little shade dip in dengue cases in that year. And as I was telling you about the case fatality rate, it was about 3.3% in 1996, came down to 0.3% and 14, sustained till 2015 to 2018, and now 2019 it was 0.1%, which has been maintained at this level. And hopefully, and dengue deaths are usually due to complications and various reasons for these complications to arise. And one of the major is if these cases are not managed well. So one factor I think which has contributed are seminars and awareness like this, that has led to awareness and sort of proper management of cases, when to test, how to treat, decrease, as ma'am was saying, decrease in usage of various drugs that were given in dengue earlier. So all this has led to decrease in mortality. That is one factor. But we still we do not know about the virus. So if it leads to more virulence, it leads to complications, then of course the mortality may go up. So that is why we have to take care of dengue fever. And this graph shows the seasonal trend from 18 to 21. And if we carefully look it's definitely post-monsoonal disease. So in our country, June onwards, the cases will rise, and this will go on till December. So this is the period, and this webinar is so well timed to be aware of various diagnostic methods and management of dengue cases. Next, ma'am. Next slide, please. So just giving you a brief about the previous one, ma'am. So giving you a brief about the virus. So it is an arbovirus. Ma'am, can we have the previous slide, please? It is an arbovirus. And I have also written about chikungunya because the clinical presentation resembles so much. Next one. And it belong. Next one, ma'am.
No, यही है मैम.
Next पे चले जाएं.
नहीं, यही है मैम. Where do you want?
Next one. We finished with this. Okay. So
Okay.
I'll talk about here. No problems. So it is yeah. So it belongs to family Flaviviridae, and it has serotypes. What I wanted to emphasize there was that dengue virus has 1, 2, 3, and 4 serotypes currently circulating in our country. And it is an RNA virus, which an envelope, which means that it can get easily activated. But the problem here is that it is transmitted by mosquitoes. So, and that is why it is seasonal and post-monsoon, because mosquitoes will increase, and it is by the Aedes mosquito. So Aedes mosquito eggs will survive for a very, very long time, for years together, when left in dry conditions. That is why once any vessel or any flower pot or anything gets infested by these eggs of these mosquitoes, even after you drain the water or the tires, the water is drained off, they dry, but years later, if there is accumulation of water and they get conducive conditions, these eggs will multiply and they will give rise to adult mosquito. Now that is the major thing that we have to prevent the disease. Next, please. So what is the role of lab? Why are we dependent on lab for certain things? That specific diagnosis, definitive diagnosis will come from the lab, but lab is also important for surveillance. So we maintain year-round surveillance, so that as soon as the cases start rising, we can catch it early. And remember, this is a notifiable disease. So as soon as we detect positivity in the laboratory, we inform the authorities with the address. That is why it is very important, whenever you're sending the test for dengue, please write the address also. Why? Because as soon as we detect positivity, we give the address to municipal corporations or local civic bodies, so that they can go and check the vector breeding there and stop the vector breeding by various integrated vector management methods. So lab has a very important role to play in surveillance as well. Then outbreak confirmation, that is for sure. When there's an outbreak, if we need not send, here it is important to know that in outbreak situation, we need not test each and every sample. It becomes important for the patient, but for management, then the clinician knows that this is an outbreak of dengue, and if the symptoms are classical, then they can right away start the treatment and monitor dengue for management. I'll come to this point a little later. Then, of course, lab has a role to play in characterization of the virus, serotype and genotype. I'll explain the importance of this also. And of course, effective intervention measures. Next slide, please. Next slide, ma'am.
Maybe
So,
there is some
for the-
lag, change, slide
ma'am.
change करने में lag आ जाता है थोड़ा सा.
Yes, ma'am. Sorry. So for any lab, now you are sending samples to all the labs, right? Because dengue test is one test which is performed by public health labs, private labs, small labs which are made in the clinician clinic. But you have to remember certain things about the laboratory diagnosis of dengue. That is why this talk has been kept. You should be taking care that the results which are given out are quality results. And how do we ensure quality results? So there are both pre-analytical factors, analytical factors, as well as post-analytical factors. So pre-analytical factors are that the standard case definition should be followed while sending the sample to the laboratory. I will come to the what is the standard case definition. We should fill in the standard performer. I'll show you the performer which has background information from the patient, and I've already emphasized why this is very important. This is very important because lab sends the information to the local civic bodies to initiate vector management. So we need a complete information. The clinical performer is required. The clinical details are required so that we can inform clinician to give some indication to manage the patients. Then the sample should be proper sample should be collected timely and stored properly if cannot be transported to lab immediately, and transported adequately whenever it is being transported to the laboratory. I will emphasize all these factors a little later. Then analytical factors are totally lab dependent, that we use standard kits, we interpret the results properly and report it properly. We need a trained technical staff, and we should quality assure in our lab by doing internal and external quality assurance. And post analytical is interpretation of the results. Next slide, please. So interpretation of results is what samples are you sending at what time and how to interpret these results of various tests that are being undertaken for diagnosis of dengue. I was talking about case definition. So this is a probable case is a case compatible with the clinical description of dengue fever, which Dr. Piyush will take. And broadly, this is an acute febrile illness, 2 to 7 days duration, with 2 or more of the following manifestations, which are headache, retrobulbar pain, myalgia, arthralgia, rash, or hemorrhagic manifestation. Or now this is non-ELISA based NS1 antigen and IgM positivity that is done by the rapid diagnostic tests. So if a person is positive by a rapid diagnostic test, that is, kind of a card test like a pregnancy test kit, it is like that. You put a drop of serum or blood of the patient and you see the lines. If the test is done by this method, then you cannot confirm the diagnosis. The program says that because there is variability in test results, that is why non-ELISA based tests should not guide the management of these patients, should not confirm the diagnosis. So this only leads to probable diagnosis, and one should not be using the rapid card tests for confirmation of diagnosis. Next slide, please. Now coming to a confirmed case. Confirmed case is a case compatible with the clinical description and one of the following. Either we have demonstrated the dengue antigen, that is the NS1 antigen by ELISA, or we have demonstrated IgM antibodies in a single sample by ELISA, and that ELISA should be mu capture or IgM capture ELISA. Now this is important. There are many types of ELISA present, but what we are saying is IgM confirmation by IgM capture ELISA. Or we detect the viral nucleic acid by PCR. Isolation of virus can also be done, but that is only for research purposes, because that, it is not possible to give the diagnosis based on isolation. So that's for research purposes. And IgG seroconversion. Suppose a lab does not have any of the kits and has IgG kits. In that case, you have to do a paired sera, that is show seroconversion. Now, what is seroconversion? That 2 samples taken apart 4 weeks apart or 15 days apart is one sample, first sample negative, second sample becomes positive, that is called seroconversion. Or first sample there is X titer and second sample is 4X titer, that is seroconversion. Or first sample is positive, suppose you have collected sample late in the disease, the first sample is positive, that is, suppose you have 4X titer, and second sample the titer falls to X, that is the titer has decreased 4 times, that is also seroconversion and confirmation of diagnosis. You see, this is how we have to interpret the results. So if you are doing IgG, you have to keep many things in mind. IgM capture ELISA, single test positive, take it as positive. NS1 antigen positive, take it as positive. NS1 antigen positive by ELISA, take it as positive. Next slide, please. So this is how we confirm the case of dengue. Right, for chikungunya, again, we don't have antigen detection, but we have to do PCR or we have to do IgM capture ELISA. So in a suspect case, it is fever with symptoms like joint pain, headache, backache, photophobia, arthralgia, and rash. Now, arthralgia is so severe in chikungunya that patient bends up. Patient literally falls on himself, and that is what the word chikungunya means. This is a Savali word which means to bend up on. So arthralgia is so bad. And probable cases, again, if you do it with the clinical definition and positivity by one of the rapid tests. And confirmed cases, either you do fourfold rise in titers, as I've already explained with IgG, or do single IgM capture titer, or we can do PCR test. Next slide, please. Next slide, please. So laboratory tests, now there are, I told you that for diagnosis of dengue, we do these tests. But for patient management, it is not required that the diagnosis is confirmed. For patient management, it is important that you do basic tests like complete blood count, liver function tests, and urine test. In complete blood count, you have to monitor the platelets and hematocrit. I'm sure Dr. Piyush will touch on the pathogenesis and tell you the importance of hematocrit that has to be monitored. That will help in patient management. Now, invariably, we'll get a call, ma'am, ye sample, we get the sample, kindly confirm the diagnosis, my patient is waiting. But do we really need a confirmatory diagnosis and that we have to put it in emergency for dengue? No. Diagnosis needs to be confirmed, but for patient management, that is not required. For patient management, what you need is platelets and hematocrit. Now this disease again, it's a tropical disease, so differential diagnosis is malaria, leptospirosis, enteric fever, rheumatic fever, reactive arthritis, rickettsial disease, COVID-19, and of course, dengue and chikungunya interrelatively. Now, this is also very important because, sometimes you have dual infections. So, if it is malaria with dengue, unless you treat for malaria, you will not see improvement in the patient. So, this is why the differential diagnosis becomes very important in tropical countries like ours. So, we have to rule out if dengue is responding, fine. If it is not responding, think of differential diagnosis, recheck, right? Especially rickettsial diseases, again, now they are on upsurge and they have a specific treatment. They have to be given doxycycline. So one has to think rationally when you have a case of dengue in hand, which is not completely responding to the treatment. Next slide, please. So now this is another very important diagram to understand. Now you see, if we look at this thing, I'll start from above. The first curve shows viremia, and this, if you carefully look, this starts 2 days before the onset of symptoms. And yes, ma'am. So it starts 2 days before the onset of symptoms, and then the viremia will last for 5 to 6 days. Now, why I'm showing you this is that if your patient, if you see in first 5 days of illness, at that point of time, you should order NS1 antigen. So, appropriate test to order at that time is NS1 antigen. We can also do virus isolation at that time and PCR at that time. But NS1 antigen is cheap. It is very effective and cost effective also. So the first 5 days of illness, we do NS1 antigen because that is the time we detect viremia. Now coming to the second, this thing. Now you see in IgM antibody titers will start rising on 5 days of illness and they will last for about 3 months. So after 5 days of illness, one should order IgM capture ELISA test. And now we know that I told you there are 4 serotypes of dengue, serotype 1, 2, and 3, and 4. So a person when suffers from dengue by a particular serotype will get immunity against the same serotype, but will be susceptible to infection by other serotypes. That is why we have primary and secondary dengue. Now, in secondary dengue, you see the IgM will rise early and will settle down early, right? Now coming to IgG titers, primary dengue, the bottom curve, the primary dengue, the IgG antibodies will start rising after 10 days and they persist for longer time. Whereas in secondary dengue, when a person has second dengue infection, IgG antibodies are already there. They will only show the surge, right? Surge in infection. That is why I said if we base our diagnosis on IgG, we have to show increase or decrease or appearance or disappearance of antibodies, right? That is why we need to test with paired sera. Next, please. So first 5 days of illness, we are ordering NS1 antigen. After that, the conventional test is IgM capture ELISA. Coming to chikungunya markers, which is again differential diagnosis of dengue. If you see this curve, the viremia starts about 4 to 5 days before the onset of symptoms, right? So in first 4-5 days, and the viremia will last up to 8 days. So in this time, we can do PCR. Subsequently, IgM antibodies will appear from about 5th to 6th days and will last for a very long time. Now, chikungunya antibodies can last for about years together. So that is why chikungunya diagnosis becomes a little challenge. IgG antibodies, once appear in blood, will remain for a long time, and that is the reason why chikungunya it started in 2006 in our country. Before that, we had chikungunya in 1964 in our country. Then it subsides because everybody becomes immune to it. So second chikungunya infection is usually does not occur. So when our all population, now that if we see Delhi or other areas, about 2/3 of the country already has had chikungunya. So we see decline in chikungunya, right? So now chikungunya is emerging in areas where it never occurred before. Then there will be a period of quiescence because these antibodies will protect us, right? Next slide, please. So dengue specific tests, virus isolation, I've said we can do it in cell lines, but it is only for reference and research. IgM MAC ELISA, that is mu capture or IgM capture ELISA. IgG paired 4-fold rise in titer 3 weeks apart. NS1 antigen detection by ELISA and molecular diagnosis. So these are dengue specific tests that we do for diagnosing the dengue. Next slide, please. We'll see one of these tests one after the other. So serology, as I've told you, it's MAC ELISA. Next slide, ma'am. Oh, this is chikungunya. So we can do MAC ELISA or PCR. Virus isolation is only for research and in reference lab. Next slide, please. So what sample should be collected? We all know that these are serological tests. So we can collect blood in plain vial. So for isolation and molecular diagnosis, we can use serum or plasma or whole blood or a topsy tissue, that is liver, spleen or lymph node. We can also detect the virus by PCR in mosquitoes, and virus can also be isolated from the mosquitoes. Next slide, please. So in first 5 days, we have to, if the illness is in first 5 days, we do NS1 antigen. And if it is after 5 days of illness, then we do the IgM capture ELISA. In first 5 days of illness, we can also do virus isolation as well as NS1 antigen detection and molecular tests. Next slide, please. Next slide, please.
लैग है कनेक्टिविटी में ना।
जी मैम।
आया स्लाइड नहीं?
Okay, so how to collect blood samples? This is easy. So we have to collect 4 to 5 ml of blood and by venipuncture after cleaning the skin properly. So I'm not going in details because it is well known. Next, please. And coming to transportation of samples, it's better to transport the samples immediately to the laboratory. If you have to store the samples, you store it in refrigerator for a day or two. If you have to store it for a longer time, then you should get the serum separated and then store the sample. Next slide, please. Next, ma'am.
This is the form in
Next one.
to be included.
Okay. So this is the form, that I was talking about, that all labs should fill in, or all the clinicians should fill in this form because this becomes important. So along with the name, age and registration number, we need a complete residential address of the patient, date of onset of illness and date of collection of sample becomes very important because if suppose you have just written for dengue, diagnosis of dengue, then we decide whether the sample has been collected in first 5 days of illness or next 5 days of or after 5 days of onset of illness, and accordingly we perform the test. This is called reflex testing. We also look at the clinical findings sometimes and decide what test needs to be done. That is why date of onset of illness, date of hospitalization, when was the sample collected, and clinical findings become very important. Next, please. Now this next slide will show the performa that we circulate, and this is also mandatory by, by the program. Next slide, please. So the program also needs that this performa, and we have to submit this performa, filled in performa, to the program. Now coming to the biosafety level, this test can be performed in any of the labs. They should have the basic, it's group 2 pathogen, doesn't get human to human transmission. So any BSL2 lab which follows standard next slide please, which follows standard precautions can do it. So virus isolation, I told you, next slide please, is done in first 4-5 days of illness, and this is how we see the virus in the cell lines. But I told you this is impractical for diagnosis and is done in well-equipped lab. It's time consuming, so does not fit in. Next slide please. So this does not fit in the clinician's perspective. It does not fit in the diagnosis of dengue. Whereas molecular tests, now all the labs have molecular labs, especially after COVID, everybody can do, most of the labs can do real-time PCR. So real-time PCR will help us differentiate between dengue and chikungunya virus also, because we have multiplex kits in this. Otherwise, for dengue diagnosis, one can do NS1 antigen instead of going for costly molecular tests. But only advantage is that if you want to distinguish with chikungunya, go in for this. This is very sensitive, specific, rapid. And, however, limitations are that this is little expensive and requires specialized lab and interpretation of results. Next slide, please. And for antigen detection, especially for dengue, NS1 antigen is, this is highly conserved glycoprotein region, and this test can come positive by if one is infected by any of the serotypes, because this is a conserved region. So whether it is it is dengue 1, 2 or 3 or 4, this test can be taken as positive when it is done by ELISA. Rapid immunochromatography tests have variable sensitivity and specificity. Next slide, please. Now, this also holds good for both primary and secondary infection. So if there is virus, you can detect NS1 antigen. And it is highly specific and has high positive predictive value, no cross reactivity with other flaviviruses. Whereas in IgM, why we are doing capture ELISA is because there was a lot of cross reactivity with other flaviviruses when we were doing plain IgM ELISA. And this test is easy to use, easy to interpret. Program recommends it. Next slide, please. And has sensitivity of more than 90 to 95%. Coming to antibody detection, as I've already discussed, we can do IgM capture ELISA test or IgG test. Next slide, please. So here we just need serum sample after 5 days of onset of illness. And if we are doing IgG, we need a paired sample for separated 14 days apart. Next slide, please. And sample should be transported properly. These are very simple, rapid tests. Reports are available the same day. And program provides us the kit. So if you send it to a public sector lab, they will not charge you anything because we get the kits from the program and it maintains the uniformity throughout the country because National Vector-Borne Disease Control Program gives us the kits. Whereas for NS1 antigen, we have to procure our own kits. Next slide, please. IgG I've already discussed. So we have to see 4-fold rise taking samples 14 days apart. Now, rapid diagnostic tests also, I have said that they are available in plenty in market. They give the results in 15 minutes, but are not reliable as they have variable sensitivity and specificity. Next, please. And quality assurance, if you are sending a sample to a good lab, make sure that they participate. They do internal quality as well as external quality assurance. We in our lab send 5% of the samples to a referral laboratory or to another laboratory to do inter-laboratory comparison. And we include both positive and negative samples. Next slide, please. So coming to the serotypes of dengue, now the slide may be a little busy, but you see we have been, I was at NCDC and now at RML have been doing serotyping since 2012. And this slide shows that all 4 serotypes are circulating in India. And of the 4, 1 predominates. And that, gives rise to this secondary dengue infection because 1 serotype is predominating. If you have suffered by, if a person has suffered by, say, dengue serotype 1 and now 2 is circulating, the person is protected by 1 but not by 2, right? And that gives rise to also antibody enhancement. Sometimes when a person gets secondary dengue infection, that may lead to complications. So this, another role of lab is it may not be important for immediate patient management that we do serotyping, but it becomes important to know which serotype is circulating because suddenly if there is, for preparedness. Now, if like dengue serotype 2 usually gives rise to a hemorrhagic manifestations. It is more virulent form of strain. So if we detect dengue serotype 2, we keep, our blood banks prepared, our clinicians prepared that, okay, this time it is dengue serotype 2, you may expect some complications. Similarly with 4. So, these serotyping helps us for basically preparing our blood banks or platelets or, management of shock, and clinicians are more prepared. And we have standard treatment guidelines for all this, which will be discussed by the next speaker. Next, please. So, dengue virus, each serotype provides specific lifetime immunity. All serotypes can cause severe and fatal infections, and there is genetic variation between serotypes that we keep monitoring. Some genetic variants within each serotype appear to be more virulent or have greater epidemic potential. So it could be either virulence or spread. Similarly, chikungunya virus, we've been tracing since 2006, since it came in our country. And till now, we have seen some mutation in the virus, which has made it to propagate in mosquitoes more. And that is why it spread more. So there was some mutation which occurred in 2011. And after that, there was huge spread of chikungunya virus. However, we have this East Central South African strain circulating in the country. There's been no change in the strain that is circulating in the country. And now what we are seeing is waning off of dengue, chikungunya infection. Next slide, please. So coming to the summary of this, one has to collect proper samples and transport it in proper cold chain. The patient information form should be completely filled because labs also notify this to local civic authorities to take public health measures and adopt integrated vector approach. Then in first 5 days of illness, one should do antigen detection, NS1 antigen detection in dengue, and RT-PCR can also be done. Virus isolation mainly for research purposes. If it is after 5 days of illness, focus on doing IgM antibodies and make sure that the IgM antibodies are detected by mu capture ELISA or IgM capture ELISA, and single sample positivity is taken as confirmatory. Lab should use standard kits, not rapid diagnostic kits, and lab should assure quality results for giving appropriate diagnosis or maintaining surveillance or doing dengue serotyping for preparedness in the country. Next slide, please. Thank you so much for your patience. Over to you, ma'am. Thank you.
Thank you, Dr. Mala, for such an elaborate diagnostic, details, what tests are available and their utility. The timings of these tests are also important. I think one take-home message for all the participants today is one is that you ask for the right test, and the timing of those tests are very important. I think you have to go, but can we quickly take the questions? There are some questions in the chat box. I think there are,
I will be here, ma'am.
Okay.
Or
Okay.
we'll see if there are any important questions then.
Maybe meanwhile you can go through the chat box if you can. Just see there are certain questions related to the diagnostics. Meanwhile, then Dr. Piyush can start. These are about EQUAS, where is it available? Then CMC Valor, rapid tests, are the rapid tests evaluated and approved by National Institute of Biologicals? We have Dr. Ashok Ratan here in the participants. I think he should have been here in the panel here. He has one question about this testing. Meanwhile, you can see that, and we can go ahead with the clinical management of dengue.
Thank you,
Welcome,
ma'am.
Dr.
I thanks Dr. Mala Chabra ma'am for sharing your valuable knowledge on different types of diagnostic methods with the appropriate method and the time when we have to conduct the diagnosis methods. And now I would like to welcome our next speaker, Dr. Piyush Jain, Professor, Department of Medicine at Atal Bihari Vajpayee Institute of Medical Science and RML Hospital. Sir has various publications in national and international journals and textbooks. He is an editorial board member of Indian Journal of Medical Specialists, awarded with ICMR International Travel Grant for ESH Milan in 2013, Srimati Pavan Kumari Jain Award by API Delhi, and Madhu Saxena Award for Best Ongoing PG in Medicine after 2010. And recently, sir has awarded with the Best Faculty Publication awarded by the RML Hospital in 2023. Sir, I request you to take the session on dengue management essentials. Over to you, sir.
Sound. I think you are on mute, Dr. Piyush.
Okay, thank you for such a nice introduction. Thank you, Dr. Sangeeta ma'am and Dr. Mala ma'am, for inviting me here. And I just share my screen. Is it visible? Is the screen visible?
Yes.
Okay. Okay, so as the previous speakers have discussed that dengue is one of an important disease, especially in our country. And mostly the whole of the country is involved now, and we see the cases from all over the country, and this is the right season when the most of the dengue cases are presenting. And as we discussed earlier, that dengue is a disease which can be prevented, and even the mortality from it can be prevented if we take a proper stepwise management of it. And if there is a delay in the management or there is improper management, then there are complications and we may lose the patients. So I will be touching upon very specific points about the dengue management. We're not going to very detailed management. We will be just having at for a primary health center or as a primary care physician, one should manage dengue. So we'll be learning about the clinical management of clinical features of dengue, management of the dengue, and what to be done, and more specifically, what not to be done while we are handling a patient of dengue. So as discussed by microbiology Mala ma'am, that dengue that it is a viral borne disease. It has 4 serotypes, den 1 to den 4, and it is transmitted from one infected person to the other by the bite of a mosquito, specifically Aedes aegypti. And Aedes is a daytime feeder, so mostly we have the bites during the daytime or in the evening time. And this mosquito has a very limited distance of 400 meters fly, so it is limited to a particular area. And why the dengue case has increased over the last few years or say is because we are having more of construction activities where there can be water stagnation can be there, the lifestyle changes, and we're not storing much of water in the tanks and other things. And these tanks are the breeding sites of the mosquito, and then it spreads. So that if we have a just outlook about the pathophysiology of dengue fever, so dengue virus infects the body, and then there are 4 mechanisms by which it causes complication. One is antibody dependent enhancement, is cytokine storm, which you heard too much in the during the COVID infection also. Then there is vasculopathy, which is like the increased permeability of the vessels is there, and there is a loss of the fluid in the third space. And then there is a coagulopathy, or there is the bleeding disorders are there. So these 4 are the basic pathophysiologic management, pathophysiology of the dengue by which the infection gets into the body. And we'll not go into detail of all these things. We will look after the clinical part, but one should remember that there is vasculopathy and coagulopathy which are causing the complications of dengue. So as we were discussing, if we see this slide, this gives that on what duration, on what day of dengue fever, or what duration it is causing what illness. So if you see in the initial 4 days is a febrile phase. We will discuss there are 3 phases of dengue. There is a febrile phase, then there is a critical phase, and then there is a defervescence or recovery phase. Now the febrile phase only lasts for 4 to 5 days, and in this there is a high grade fever is there. And as the fever is subsiding, there is the critical phase. This 4th to 6th day of the fever or the illness is the most critical, where we will have the most complications, like it will have can have bleeding manifestations. In these days the patient can go into shock, and there can be various severe organ derangements can be there. So initially 4 days the fever patient is having fever, then the fever is subsiding. So generally the patients think now that fever is subsiding, we are getting better, but that is the problem with dengue, that once the fever is subsiding, then there is the complications of dengue develop. If we see the laboratory changes also, so as the fever is subsiding on in the critical phase, the hematocrit is very high and the platelets gets reduced. And if you see the antibodies, they are developed after 4 to 5th days. The antibodies are developing when the viremia is coming down, virus load is coming down. And after 6th day we have the recovery phase, where there is can be fluid overload and other things are recovering. So we just see to it in detail for the next few slides. Just keep this slide in your mind, because this will give an overview of all the stages of the dengue and what will happen in which day of the duration of the illness. Okay, so if we see the clinical features now, the disease, why it is that some patients are having severe dengue, some patients are having mild dengue, some patients even just don't have just fever and it goes on, passes on. So the disease manifestations depends on many factors like age, The elderly people or the infants can have a severe disease. The nutrition status of the patient, immune status, those patients who are on immunocompromised status or who have on immunosuppressant drugs, they can have severe dengue. Presence of comorbidities like hypertension, diabetes, CKD, all these can lead to severe dengue. So, and which type of strain, like Dr. Mala was discussing, like then two can have severe hemorrhagic manifestations. So which type strain is prevalent this year, and that can have a severe dengue, and whether it's a primary or a secondary dengue. Like we discussed, in primary is when the first time infection is there, secondary is there when the suppose then one was the earlier infection and this time there is then two infection, so that becomes a secondary dengue infection, and that can have severe manifestations. So if there, because there are a lot of antibodies are involved, so there, if there is a one serotype infection earlier and now some other serotype is there, so that can secondary dengue can have severe manifestations. So disease manifestation will depend on these factors like age, immune status, comorbidities, type of strain, primary or secondary infection. The average incubation period is like a 4 to 6 days, and generally the symptoms start with fever and some non-constitutional symptoms, non-specific constitutional symptoms such as headache, backache, malaise, etc. So these it's just like a viral fever, but sometimes it leads to complications. So as we discussed, there are three phases: febrile phase, critical phase, and convalescence or recovery phase. So in the febrile phase, there is a characterized by sudden rise of body temperature. There can be high-grade fever, generally without chills and rigor, but there can be high-grade fever, and the fever may last for 2 to 7 days and is associated with headache. These are prominent features: headache, flushing. They can be vomiting, myalgias. Myalgias is very severe in any viral fever, especially dengue. There can be arthralgias. There is retroorbital pain. Many patients just comes that we are having fever and then there is pain over the eyes. So retroorbital pain, epigastric pain is there. Some patients develop small some macular rash. Now the rash is primary maculopapular or rubiliform, and it usually develops on third to fourth day of fever and occurs mostly on the face, neck, chest, and abdomen. Then there can be facial puffiness, congestion, conjunctival congestion can be there, pharyngeal erythema, lymphadenopathy. All these are the features. So basically, it's just like a viral fever. Have initial 4 days are of febrile phase, are of viral fever, specifically with high grade fever, headache, retroorbital pain, and congestion. After this, as we saw in that image, that after the febrile phase is getting over by fourth or fifth day, 5 to 10% of the patients may progress to the critical phase. Now, this is the critical phase, and what will happen is that in this phase there can be vasculopathy or coagulopathy. In vasculopathy, there can be permeability of the fluid into the third spaces. There can be a lot of shock. Patient can go into shock, and in coagulopathy, there can be the like bleeding can be there, excessive bleeding, hemoconcentration can be there. So these are the manifestations or the complicated manifestations of dengue which will develop during the critical phase once the fever is subsiding. So it is common in history with previous dengue infection. When the secondary infection is there, then patients are more likely to have the critical phase. And in the patients who are having comorbidities or active co-infections of tuberculosis, malaria, and all these infections, these patients are more likely to develop this, going to the critical phase. Now, this is very important thing. When the patient is going into the critical phase, we have to look for these warning signs and symptoms. Just remember them, warning signs, and very important. We should all tell our patients about the warning signs and symptoms. What is it? Persistent vomiting. Patient is not able to accept orally. Whatever he takes, he vomits out. There's severe abdominal pain and tenderness. This can be due to the ascites, this can be due to gastritis, even pancreatitis have been noted. So there is severe pain, abdominal pain and tenderness. There can be restlessness, lethargy, and even unconsciousness or encephalitic changes. There can be bleeding manifestations. Ask the patient for any bleeding from any side. There will be sometimes melena, just overt bleeding we can be there, which patient may not be even aware of it. So you have to ask for these signs: melena, epistaxis, gum bleeding, excessive menstrual bleeding, hematuria. So these should be asked for. There can be syncope or giddiness as a patient might go into shock. There can be clinical fluid accumulation. Look for the ascites, pleural effusion. Patient will just complain that he's having tenderness, he's having distension of abdomen, pain abdomen. So look for the ascites. It might be having tachypnea. Look for the pleural effusion. There will be hepatomegaly, and if we do the investigations, there can be progressive increase in the hematocrit with a rapid decrease in platelet count. Now, this point I will come once again. Mostly the dengue is synonymous in the layman condition is synonymous with the decreased platelet count. Platelet kam ho gayi hai. So just concern. There's nothing much to worry about. The most important concern for any person is that if there's a dengue, platelets kitni hai. So platelet is one of the important thing, but platelet is not the only thing. And as a clinicians, as physicians, we should look for the hematocrit. That will give a better idea of hemoconcentration and hematocrit, and that we need the fluid therapy. Platelets may decrease even at a later stage. So first condition to change might be the hematocrit. So look for the hematocrit. Look for the TLC. TLC will be leukopenia will be there. Don't see that the platelet count is okay 1 lakh, you are fine. Platelet count has gone to 70,000. Oh, you are getting severe dengue, all the complications. No, platelets are important. They will also part of the complicated dengue, but look for the more important is the hematocrit, TLC, and other warning signs. Warning signs. Look for the ascites. If you this patient may not have noted himself. That is the job of the clinician to look for these features. And once this febrile phase and critical phase is over for 3-4 days, after 3-4 days, the patient gets into the recovery phase, and the extracellular fluid, which are lost to capillary leakage, it returns back to the circulatory system. The signs of shock is improving. The blood pressure is now getting normal. The tachycardia, which was there, is settling down. Tachypnea may be recovering. This phase again lasts for 3 to 4 days, and patient might be having a rash with pruritus. So again, if the pruritus is an important feature here, the pruritus is there with the rash, so it may be patient is going into the recovery phase. And at this time, we have to look for the fluid therapy. If we give a lot of fluids, the patient might go into the fluid overload. So patients with severe or shock, organ involvement, and or other issues can expect a longer recovery time. Those patients who have gone into complications during the critical phase may take even longer to recover. Now, how do we approach to a patient suspected to offer dengue? So generally patient comes with fever. The most important thing is to ask to approach is a history. Now history is very important, as we have been told right from our undergraduate day that a history of any illness is taking is very important. So ask the history, like what duration of fever is there. This will give a very detailed idea about what disease we are dealing with. Suppose the patient says that history is long, fever is for last 8 to 10 days. So the dengue fever or viral fever are less likely. Look for the alternative diagnosis. It might be enteric fever. It might be malaria. If not treated, malaria fever can be last for this thing. But generally, the viral fever or dengue fever will not last for 8 to 10 days. By that time, the fever would have subsided and the patient will be in the other complications. But if the fever is still persisting, then look for the alternatives or the diagnosis. They're very important to look. How is the fever pattern is there? High grade fever with chills and rigor, look for the malaria. More common, look for the UTIs. Generally, the dengue patient will have high grade fever, but less likely to have the chills and rigors. Then ask for the warning signs. What pattern, what is the input output, how much is the, is whether is persistent vomiting, whether any other system is involved, how about the hemorrhages. To look for these warning signs. Is there any change in mental state, seizures, or consciousness? Very important to ask all these things. Input output monitoring. Then very good idea you can get, because dengue generally comes when the rains are there in a rainy season and all that thing, though they can be isolated cases otherwise. So if there is an epidemic going on or the outbreak is going on in the locality you are serving, look for that. If there is a patient of dengue in the family or in the neighborhood, there is a history of such patient there, so dengue is more likely, or a travel history. So ask these relevant history. Then we should know about the coexisting conditions if there is any history of diabetes, hypertension, because this will make the disease more severe, and we need to look for the complications for dengue in these, and more vigilant in the patients who are having these comorbidities. Other thing is a simple test which can be done in the clinics in the outpatient department is the tourniquet test. Tourniquet test is a simple test. You just tie the blood pressure cuff and raise it. The mercury should be raised to a level between the systolic and the diastolic blood pressure for 5 minutes, and then you look for the in the one on the this forearm, you look for how many petechiae developed in a area of 2.5 centimeter square or 1 inch area, how many petechiae are developing. If there is more than 10, it is be suspicious. The test is positive, and in dengue, that there can be more than 20 petechiae per square inch of area. So it's a simple test, outpatient department test. You can just do this test. You can get an idea that yes, the platelets are decreasing, or there is a petechial hemorrhage is going on. Now, this is the type of the rash or petechial hemorrhages that the patient might develop. Now, earlier we used to use the terms like dengue hemorrhagic fever, dengue shock syndrome, dengue fever. For last few years, these terminologies have been revised, and now what we used is mild, moderate, and severe dengue. Now, mild dengue is that the dengue test is positive. There is an infection of dengue is positive. Patient is having fever and other symptoms like nausea, vomiting, rash, headache. But there is absence of warning signs. There is no persistent vomiting. There is no space fluid collection. There is no just remember the warning sign. There is no abdominal pain. There is no restlessness, sudden behavior changes, altered sensorium. There is no bleeding manifestations, and their liver is not enlarged. So hematocrit is not raised. So the warning signs are absent in patient of mild dengue. Understand? So the patient is having mild dengue, but the warning signs are absent. And if we do investigation, there can be leukopenia can be present, and platelet count and hematocrit are in the normal range in the mild dengue. If the patient is moderate to severe dengue, then the platelet count will decrease and hematocrit will rise. It is further subdivided as A1 and A2. A1 is simple dengue without warning signs. A2 is dengue without warning signs with comorbidities. If the comorbidities or risk factors are present, then we called it A2. So these will be just A2, B2 are given just for the management purposes. Then there is moderate dengue. What is moderate dengue? Is dengue with warning signs. Now there is fever with warning signs and symptoms, and it usually occurs during the critical phase at the end of the febrile phase. Again, it is subdivided as B1 and B2. B2 is warning signs with comorbidities. If the comorbidities are present, warning signs are present, there is history of febrile illness, then we term this as B2 or moderate dengue. Then what is severe dengue? Severe dengue is when there is symptoms and signs of shock, plasma leak, and organ dysfunction. So the patient is going into shock. There is third space collection, there is plasma leakage, and there is severe organ dysfunction. So severe plasma leakage leads to shock. It leads to fluid accumulation with respiratory distress. There can be severe bleeding. There can be severe organ dysfunction. There can be AST and ALT are very high, more than 1000, and there can be impaired in consciousness. GCS is less than 9/15. So we have to look for this severe dengue. Now, if we see the severe organ dysfunction, it can be involve the CNS system. There can be febrile seizures. There can be encephalitis, encephalopathy. There can be intracranial hemorrhages, thrombosis, There can be neuropathies like Guillain-Barré syndrome. There can be transverse myelitis. So these are the signs and symptoms of severe organ dysfunction. If we see the liver, there can be hepatitis, there can be fulminant hepatic failure, already AST, ALT are very high. They can acalculous cholecystitis. Now you will see this term very common in dengue patients, acalculous cholecystitis. These patients will get an ultrasound which will be labeling them as acalculous cholecystitis. Now this is a severe organ dysfunction, one of the very important cause of severe abdominal pain. Acute pancreatitis can be there, acute parotitis can be there. There can be kidney dysfunction like acute renal failure, hemolytic uric syndrome can be there. Then there can be others like post-infectious fatigue syndrome, depression, hallucination, psychosis, alopecia. So all these are severe organ dysfunction. The lungs can be having the ARDS like picture, or pulmonary edema can be there in the lungs. So then there can be heart can be involved with myocarditis, cardiogenic shock. So all these are the severe organ dysfunction. So this we all should look for. And if these are present, any of these are present, then the patient is in the category C or severe dengue. Now, according to the classification of the dengue patient, we will decide the management part. If the patient is having mild dengue, that is a dengue patient is having fever with some constitutional symptoms, but without any warning signs, the patient may be managed on the OPD basis. If the patient is having moderate dengue, then either that is the patient is having features of fever, constitutional symptoms along with any of the warning sign, then these patients should be monitored closely or should be observed closely. So better is to admit them and treat them, because there the monitoring can be done well. So there should be admission for in-hospital management. If the patient is having severe dengue, that is, there are signs of vascular leakage, there are signs of shock, there are signs of organ dysfunction, massive bleeding, then the patient requires emergency treatment, and management should be done in a tertiary care hospital, preferably in an ICU. So first is when there are mild dengue. We just discussed all these things in detailed thing. When the mild dengue is there is no warning signs. So patient should be treated on the OPD basis. Patient can be sent home with drugs like paracetamol. So we have to control the fever in this phase. We have advised them acetaminophen or paracetamol. NSAID should not be advised. It's a common practice. The patient will complain that I'm having high grade fever, which is not coming down with paracetamol. Even after taking paracetamol, the fever is high, and either the chemist or the patient himself are too keen to take Comiflame or some combination with Flexon, all these drugs which are having NSAIDs in them. So this should be avoided. Meftal, it's a very common practice. Meftal, Combiflame, Flexon are being took just to decrease the fever. So we have to advise them that the fever will come down, and with paracetamol, you have to take only paracetamol. It can be taken 4 times a day, every 6 hourly it can be taken, and do sponging. You can even advise them to take a lukewarm water bath, but do not advise them to take NSAIDs, and NSAIDs are totally contraindicated in the patient of dengue, because this can further lead to the decreased platelet count in the later phase. And these are the common patients who will develop thrombocytopenia in later phase and bleeding manifestations. So it should be avoided. If the fever is still not coming out with the oral paracetamol, another thing that you can do is give an IV paracetamol. That will help. If the patient is having very high grade fever and you are worried, then you can give IV paracetamol, but no NSAID should be given, and IM injection should also be avoided. No IM injections. So generally we have the IM paracetamol preparation that should be avoided. We can just give IV paracetamol in severe cases of high grade fever. So these patients are very mild. They don't have much of complications. So just give temperature control with paracetamol and sponging. Then there should be adequate bed rest. In any viral illness, if you not adequate bed rest, not bed rest is required, but adequate rest is required. If you do adequate rest, these have a early recovery. If these people are exerting themselves, then they can have a prolonged course of the intubation. So bed rest is not required. It's wrongly here. Bed rest is just adequate rest. More importantly is have fluids, adequate oral fluids in the form of ORS, juices, coconut juice, anything can be taken, but they should take a lot of liquids. So ORS and coconut juices may be taken, and even if the patient is not taking accepting meals, so don't force it for the meal. Just ask them to maintain the hydration. And then, most importantly, when you ask the patient to in the OPD, tell them about the warning signs, what they should look for. That if they have severe abdominal pain, vomiting, they should come back to the hospital. They should visit back to you. If there's any site of bleeding, especially from the bleeding from nose, gums, melena, that should be told them. And if there is the drowsiness or the consciousness state is changed, then the patient should be brought back. And if there is cold clammy skin, then the patient should be brought back, because that may be a sign of shock, or there is tachypnea. There is severe tachypnea is there. Patient should be visiting the healthcare center. When we have this is about the mild dengue patient. If we have a moderate or severe dengue, then the general condition, we should look for the appetite, vomiting, bleeding, and other warning signs and symptoms. We should look for the perfusion, peripheral perfusion, because these patients will be mostly in shock. Then vital signs such as temperature should be monitored very closely. And then hematocrit should be done, because these patients will have a increased hematocrit. This was what I was talking about, that this will, even at this stage, platelets may be normal, but the hematocrit will be rising. So look for this sign. This shows there is a hemoconcentration. There is hematocrit is rising. Start giving the IV fluids and urine output, because most of the things that this in modern severe will be looking after the fluid therapy. If the patients are admitted, we should look for some other special investigations, like glucose should be monitored. We should look for the lactate levels in AVGs, because this patient might be in the shock. The lactic acids might be raised. Look for the electrolytes. If there is a lot of fluid is there, the patient might having hyponatremia, dilutional hyponatremia might be there. So look for the serum electrolytes. Renal function test, that might be patient might be going to AKIs. So look for the renal function test, liver function test, because there can be hepatitis, AST, ALT might be raised in severe dengue. So look for the LFTs. Chest X-ray should be done to look for the pleural effusion. Blood grouping should be done, because we might need to transfuse them with the blood or platelets. And then ultrasound should be done to look for any ascites, to look for the acalculous cholecystitis. So all this should be, investigation should be done when the patient is admitted in the hospital with moderate or severe dengue. So if we are having, this was a common moderate and severe dengue. If we are having a moderate dengue patient, they admitted, encourage oral fluids. If the patient is persistent vomiting and unable to accept orally or not able to tolerate, then start the IV fluid. The fluid of choice is the crystalloids, isotonic crystalloid fluid, preferably NS, 0.9% NS or ringer lactate. Avoid DNS. Dextrose containing fluid should be avoided, because again they have an impact on the platelet dysfunction. So avoid dextrose containing fluid. Give them a normal saline or ringer lactate. We can start, if the patient is in shock, we can start with 7 to 10 ml per kg crystalloid solution in 1 hour. And as the patient's condition is improving, we can decrease the dose. We can give a 5 to 7 ml per kg per hour for next 2 to 4 hours. After that, we can decrease down to 3 to 5 ml per kg per hour for next 2 to 4 hours, then 2 to 4 ml per kg per hour for 2 to 4 hours. So simple, start with 7 to 10, then 5 to 7, 3 to 5, and 2 to 4 ml per kg per hour. Every 2 hourly change. If after giving a bolus dose and continuing on the 5 to 7 ml infusion, the hematocrit is still high, it is more than 45%. Again, give a second bolus dose of crystalloids for 1 hour. And if there is no improvement, even after giving a second bolus dose, we have to manage the patient as the group C or the severe dengue. We'll just discuss what is the change in there. So this is the thing. And then this hematocrit should be taken before starting the IV fluids. Just take the sample and start the IV fluid. Don't wait for the report. It may take some time, but do collect the sample, because the hematocrit might vary, may not give a true value if you are already infusing the patient. So if a patient is having severe dengue, they should be stabilized with what we see, the ABC airways, breathing and circulation should be stabilized and referred to an admission for a hospital, tertiary care hospital, or any hospital which has blood transfusion facilities. There is the role of IV fluid therapy is very important. This is a thing which we can manage well and we can save the patient, and it can be just life saving. Any delay, any misinterpretation of the IV fluids can lose the patient. So we have to be very careful in giving the IV fluid resuscitation. Again, we prefer a crystalloid solution sufficient to maintain an effective circulation, and usually for 24 to 48 hours, and adjust fluid as per the patient status and monitor vitals every 5 to 30 minutes. So close monitoring of the vital and the patient's conscious status and other status. If even after giving IV fluids, crystalloids, the patient's blood pressure is not improving, we might think of using a hyper-oncotic colloid solution like Dextran 40 or SARS solution may be used if we see that the massive plasma leakage is there and those not responding to the maximum volume of crystalloids. If the blood pressure is still not recordable, we can start with the inotropes. So the shock is refractory. If the shock is refractory, we have to use inotropes should be considered. We should look for the cause of the cardiogenic shock, get an ECG done, look for any other thing which is causing the decreased blood pressure, whether it may be an MI along with this, myocarditis, whether it is a cardiogenic shock. So treat accordingly. Look for the septic shock. Just don't think it is a dengue. It might be a dengue with a super added bacterial infection. So look for the septic shock. Evaluate metabolic causes and organ dysfunction. Evaluate concomitant medical conditions and stabilize the baseline condition. Evaluate persistent acidosis and risk of hemorrhage and treat accordingly. These all should be taken care of if the patient's shock is refractory to the colloids or to the crystalloids. And once you give a good amount of crystalloids and the patient is recovering, so when to stop the IV fluid? When the patient blood pressure has become normal, the pulse and peripheral perfusion is good, there is decrease in the hematocrit. Hematocrit is coming to the normal level, and there is fever is not there. There is no use of requirement of antipyretics for last 24 to 48 hours. The bowel abdominal complaints are improving, the urine output is improving, then we should think of decreasing and stopping the IV fluids. If we continue IV fluids for a longer time, now I remember there was this was a febrile phase, then there was the critical phase, and third was the recovering phase. Now the patient is recovering, and still we are continuing with the high doses of IV fluids. What will it lead to? It will lead to the fluid overload. The patient might get the pulmonary edema. So we have to look at that time that once the things are recovering, then decrease the IV fluid. This is another important thing. Everything was recovering well, but suddenly we forgot to change the orders and we are continuing with high dose fluids. So then the patient might go into the fluid overload complications. Very important thing, we all just jump towards the transfusion. Transfusion is not very important. Transfusion is important. Transfusion is not the treatment of choice. So first manage the IV fluids. Fluid therapy is important, and if the patient, and just don't give platelets for that there is thrombocytopenia. There is no prophylaxis. Either platelet transfusion is required. Platelets transfusion is required if the platelet count is less than 10,000 without any bleeding, or if the patient is having bleeding. Then at bleeding, then at any count we can transfuse. But if the patient is not having bleeding, then don't transfuse until unless platelet count is less than 10,000. But yes, these patients require very importantly monitoring. You might require to do twice a day platelet count. Suppose the platelet count morning is 30,000 and the patient is having no signs of bleeding, so continue with the management. Don't in a hurry to transfuse, but if in the but get a repeat platelet count in the evening. If they are further dropping less than 10,000, then you need to transfuse. If they're again 20,000, 25,000, just do repeat in the morning. So we have to be very careful about the transfusion because these platelets, they are antibodies. Why the transfusion not required at this thing? Because there are antibodies in the system, there are antibodies in the blood, and whatever transfusion you will do, that platelet will also be damaged. So there's no point. So that the pathophysiology of dengue is going on. These antibodies are killing the platelets. So whatever the normal platelets were diffused, now even if you transfuse, it will kill those platelets also. So there is no benefit of transfusion. You have to wait for the viremia to settle down, to look for the complications to settle down. But yes, we have to give the platelets if there is bleeding, because we have to stop that. So in that case, the platelet transfusion is there. They can be single donor platelet count transfusion, or they can be random donor. So single donor platelet count platelet transfusion is better, because that is almost a jumbo pack, and that is equivalent to 4 to 5 packs of the RDP which we give. But that is little expensive, as apheresis has to be done. So there's some kit is required. It might cost some cost, but it is better. So that will give a rapid rise in the platelet count. And if we do the transfusion without the indication, we are just adding to the transfusion reactions, complications, and wastage of the resources. So be careful about that thing. Then there are some special situations like pregnancy. Now, pregnancy, as we know, there is a risk to the life of both mother and fetus. So that has to be taken care of, and there can be fetal complications that has to be managed. And there's a risk of transmission from mother to child also, if the viremia during labor, if during labor the virus load is very high, high viremia is there can be risk of vertical transmission from mother to child. And pregnancy is a hypervolumic state, so pleural effusion, ascites, hypertension may manifest easily when the infection is there. So strict vital monitoring, frequent platelet count, coagulation profile testing should be done in the patients and the pregnant patients with dengue fever. And fluid overload has to be managed very well. We have to be very careful about the fluid overload, because the patient is already having hypervolemia. If you give too much fluids, it might lead to ARDS and pulmonary edema. Just simple tips. We all have been managing dengue well. We all know about it. Just a revision of few tips which we can give to our patients and help in decreasing the mortality and morbidity due to dengue. Cover all water tanks and containers with tight lids. This is a common thing, because we have kept the tanks, on the overhead tanks are there. We are not frequently visiting them. The lid is not there, and it becomes a site for the mosquito breeding. Then there are unused containers or tires are all these present on the terraces. So that should be disposed of or covered well, so that these do not lead to the water collection and breeding of the mosquitoes. We can advise our patients to use mosquito repellents, to use bed nets, because that will or wear the full sleeve shirts, cover the trousers. Everything can be as much body part can be covered, especially in the children, and because this will prevent the transmission of the virus. Rainy season just comes after summer seasons. We all have the coolers, water coolers, especially in the rural areas, slum areas. These water coolers are there. They're not cleaned properly. There is some water in this. This leads to the mosquito breeding site, and that develops these mosquito-borne infections. So we should ask them either to clean them, dry them, or to add some kerosene oil, which can a layer of kerosene over the water, which will prevent the mosquito breeding. Do not allow water to stagnate anywhere. Throw away the old tires, junks, containers. Don't depend on platelet counts for diagnosis. Very important, as I mean, overemphasizing upon this thing. We should not just look for the platelet counts. Then there are people who are just having a self medication कि सबको डेंगू हो रहा है, मुझे भी डेंगू हो गया होगा, केमिस्ट से जाके एक कॉम्बिफ्रिम ले लिया, एक मेफ्टाल ले लिया, उससे फीवर कम हो जाएगा. That should be discouraged. That practice has to be discouraged. No NSAID should be given. We should look for the warning signs. A person in the family having dengue may not require the same treatment of the other person who also having dengue. He may not be having the complications. So we should look for the warning signs. They should be seen by the physician and advise accordingly. Don't take any painkillers and NSAIDs, ibuprofen. Only thing advised is the paracetamol. That is safe in dengue. So to conclude, dengue is preventable. We have to take some environmental precautions and take protective measures. Avoid NSAIDs, very strictly to avoid NSAIDs. Use paracetamol or acetaminophen. Look and tell your patients about the warning signs. Maintain adequate hydration, either orally if the patient is accepting orally. If the patient is not accepting orally, give IV fluid therapy, mainly with the crystalloids, and don't rush for platelets until and unless it's bleeding or absolutely indicated. Thank you. Thanks a lot for your kind listening.
Thank you, Dr. Piyush, for elaborate management profile. I think you have covered all the points which are necessary for management of dengue fever, right from the different phases to different stages, and particularly the fluid management part. If you allow, we can start taking the questions. The one immediate question I can see in the chat is, people do panic about platelet. There were some questions, some of them have been answered, but some questions are like, how frequently should you be doing platelet count before any bleeding happens and after platelet transfusion? How often should you be doing platelet counts?
So, ma'am, there is no fixed protocol for it. That is the clinician's perspective, and he has to evaluate the patient as a whole. That, like I said, if the patient platelets are dropping, then and the patient condition is not stable, then we should do it twice a day at least. It can be even more frequently, but at least twice a day if the patient is unstable and platelets are dropping frequently with a very rapid otherwise, we can just give out 24 hours. So this will depend on which phase the patient is presenting, how is the other clinical conditions, whether he requires any transfusion, is there any bleeding from any side. All these factors have to be taken into consideration. Generally, we do after 12 hours or 24 hours.
Okay, I hope this question has been answered well. Dr. Mala has to leave in another 10 minutes. Dr. Piyush, if you are around, we can
Sure,
take.
ma'am, sure.
Okay. I think there were questions around quality assurance for dengue. You did mention about external quality assurance program for dengue, but I think they want to know where is it available and how can they be using.
So, ma'am, there are two aspects to it. One is the external quality assurance program, the classical one. It's one can enroll for this program at CMC Vellore. Another one which the National Vector-borne Disease Control Program promotes is the interlaboratory comparison. So interlaboratory, they have identified some regional labs where the other labs can send samples. So it is little different from EQUAS, but the 5% of positives and 5% of negative tested samples in the lab can be sent to the reference lab, regional labs where they test. It's a kind of a double blind, so you can maintain the interlaboratory comparison of results. So program promotes this because the participating lab can directly send the samples to the identified reference lab. So program, what it does, it connects the labs to the regional labs, and it becomes much easier than the EQUAS. Of course, EQUAS is more standardized and better, but this becomes easier for the program to manage. So
Okay.
that is about EQUAS.
Then there is a question from Dr. Ashok Ratan about rapid tests. Are they evaluated and approved by National Institute of Biologicals?
I wish they do it, ma'am. So it is mandated, mandate of National Institute of Biologicals to evaluate various kits that are available in the country, but I'm not sure. I don't think it's done, because if it was done, then probably some of the kits will come in the program. But we've seen that there is variable sensitivity and specificity of the kits available for the reason that they have not been evaluated by the National Institute of Biologicals.
Okay. Since severe infection occurs in secondary infection, detection of NS1 and IgG would have been very helpful for early warning of the possibility of severe dengue.
That's absolutely right, ma'am. As we have shown that the viremia and generation of antibodies, IgM and IgG, in that slide, If there is NS1 antigen along with IgG antibodies, definitely it indicates secondary infection, which is pointing to severe infection. It can be severe infection. So this is absolutely right. Sometimes we see NS1 antigen and IgG coming positive instead of IgM. That indicates that a person has had previous dengue and now there is surge of IgG antibodies, and sometimes in this surge there will be low levels of IgM antibodies which may not be detected. So I think that is a very good thing to say, that NS1 and IgG detection may indicate severe dengue infection. At least it indicates secondary dengue infection, if not severe.
Okay. What about those cases which test NS1 antigen, I think, but is IgM negative?
Well, this is a little difficult question to answer, because NS1 antigen kits which are currently available have high sensitivity and specificity. So false negativity is much less in NS1. So one of the reason would be that the person does not have dengue and is detecting falsely detecting NS1 antibodies, but this possibility is much less. NS1 antigen and IgM detection, IgM negative, one case would be that IgM antibodies are very low. That is why they are not detected. In such cases, one should also look for IgG antibodies, as we have just discussed. But a small percentage of cases we've seen where NS1 antigen comes positive and IgM is not detected. That could also be due to patient's own immune response. What is the immunological status of the patient? So these are a couple of things that we have to keep in mind when we interpret the results. Very good question, ma'am.
Okay. Then I think this has been answered. There is a question. Kindly educate policymakers to get central dengue prevention eradication program at national state levels. There is an urgent need of this era of single child. It is pathetic to lose life due to mosquito bite. I think there is a program, National Vector.
Yes, ma'am.
It
There's
is there, and for many years it has been there, and everybody has to come together. Actually, it is not only for the policy maker. We as the healthcare providers, healthcare service providers, the public, everyone has to come together and fight this infection.
Yes, ma'am. It is actually community and behavioral change. We should be
Yeah.
very vigilant about what is happening around us. Sometimes now, in this modern era, we close our eyes to our community. We think कि ठीक है, मेरा क्या मतलब है. But mosquitoes will not see. So if we see stagnation of water or coconut shells thrown somewhere, or even in barks of the trees, if there are holes, there is accumulation of water, there will be mosquito breeding. And then we have flower pots everywhere, bamboo shoots everywhere. So I think it is our social responsibility also that we don't let the water accumulate around us, and sort of be aware. And it is not very difficult to detect mosquito breeding in water. So be aware of it. Throw oil on it, so that the mosquito doesn't breed, and aeration is cut in the water. Plus, don't store water, invert the pots, and be careful when we have trays under the flower pots or gamlas. Those trays, there will be leakage of water, and we've seen so many times, we've seen mosquito breeding there. So small things like this, if we are aware of this, then I think even program is doing it, should do it, should strengthen their efforts. Having said that, our own social responsibility, and it's very rightly said, losing life to dengue in this era, as Dr. Piyush said, beautifully explained about the management of cases. Well, I think in this era, if we lose life to dengue, is sad.
Yeah,
So we
definitely.
should take the social responsibility also
This is
along with the program.
preventable. This disease is preventable.
Large extent,
I
yes.
think statistics regarding statistics of dengue, Somebody has written that the NVBD is underplaying. They want their government jobs in place, but forgetting none of us can escape mosquito bite.
Mm. Well, I can't say much, but dengue is notifiable of course, the problem comes when the statistic varies is when we are doing tests with rapid antigen tests. There will be a lot of positivity. I've seen clinicians, especially in private sector, they make the person sit outside their clinic to do the rapid antigen test, and then the person goes in with the rapid antigen kit to the clinician, and they will interpret the result and manage accordingly. So those tests program will not count it, and they have variable sensitivity specificity. So the problem is that they will not count these tests as confirmed cases of dengue. So that sometimes there may be discrepancy on this. Now, National Center for Disease Control, they, if they're going in the field, sometimes they take this rapid antigen test kit. So even government is using, but they're using it with caution, because they want early detection. So if they get positivity, they get it confirmed by the confirmatory test. So sometimes there will be discrepancy like this, but as of now, program will consider a confirmed case only if it is done by ELISA tests.
I think one more reason you had already pointed out in your presentation, notification is required,
Yes,
and that complete information is also required for a
absolutely.
good interpretation of this. So all of us have some role to play in this. Okay, then there is a next question. Many false positive results come like IgM, scrub typhus, IgM, leptospirosis, along with dengue fever.
Um, Again, what is the test being done is important. Are we doing confirmatory tests? Now, dengue cross reacts with usually with other arboviral infection. That is why we've opted for mu capture ELISA test. But in COVID times, we saw some cross reactivity with typhoid also. But was it dengue? So if we are detecting dengue NS1 antigen and having mild typhoid test positive, then we should definitely focus on dengue. Now typhoid again is a rapid test and has its own. So like that, similarly scrub typhus, you have to do ELISA. If you are doing a rapid test, again there will be variable sensitivity and specificity. To qualify this statement, one has to really interpret the results and the tests very carefully.
Then there is a question about if IgM is positive, for how IgM is positive for how long with IgG negative?
IgM positive and IgG. So in primary dengue infection, IgM will start rising after 5 days of illness, whereas IgG will appear in primary infections after 10 or 12 days of illness. So that is the time that only IgM will be detected, IgG may not be detected. Whereas in secondary dengue, IgG starts, there's sudden rise in IgG, sometimes even before IgM. So again, interpretation of results. So there would be in primary dengue, there's period when IgM only will be positive and IgG will start rising after 15 days, 10 to 12 days.
I think you've already answered, but let me just ask this question. Is there any time during febrile illness when both NS1 and IgM can be detected?
Yes, ma'am. Now, NS1 antigen, as I've shown in that graph, again, that graph is NS antigen is at its peak in early phase, so up to 5 days. After it starts declining. But we have detected NS1 antigen up to 10 days also. And IgM will start rising after 5 days. So there is again this period of between 5 to 10 days of post onset of illness that NS1 and IgM both may be detected.
I think there is just one more question about what do you mean by fourfold rise, fivefold increase titers? Can you just repeat that?
Fourfold rise in titers. So fourfold rise in titers pertains to detection of IgG antibodies. As I've said that single IgG antibody detection does not have any meaning because we've seen how antigen and antibody play in the body once the infection starts. So I said seroconversion. Seroconversion is when you detect IgG antibodies at a point of time, and after 14 days, if you repeat the test, there is, suppose there were X amount of, say, 10 international units of IgG, and it has risen to 40 international units. That is fourfold rise, right? And suppose you are detecting late in the disease, suppose you are detecting 40 international units or 400 international units of IgG antibodies, and 15 days later, they fall to 100 international units. That indicates recovery. Again, that indicates active infection. That patient had active dengue. And seroconversion is that you are not detecting at day 0, but after 14 days you're detecting. So getting converted from negative to positive is also indicative of active infection. On the other hand, suppose you have high titers and you then come down to a very low level, that is also seroconversion. So that is what I meant by fourfold rise or fall in titers.
Thank you, Dr. Mala, for taking up all the questions and answering them. I hope the participants are now satisfied with this. I know you have to leave. Thank you for joining us.
Thank you. Thank you. Thank you for the opportunity. Thank you, Dr. Piyush, Dr. Sangeeta. It was just wonderful being here. It was break from the field investigations. See you people. Bye-bye.
Okay. Okay, Dr. Piyush, and a lot of questions for you.
Yes, ma'am.
Okay, there is one person question, one typical case problem. I think I can come down to that later, but let's take the general questions right now. If the patient is suffering from increased TLC, DLC, along with high platelet count, then what do we give to the patient?
See, ma'am, dengue patient generally will not have the increased TLC. Either they will be having the leukopenia or the normal TLC. If the TLC is high, then we should look for the secondary bacterial infections or some alternative diagnosis. We should look for if there is any, say, UTI, pneumonia, if they are present. So because generally the dengue will not lead to increased TLC. So accordingly, we have to give the antibiotics. Otherwise, antibiotics have no role in the this viral infection, in the dengue infection. But when you are having increased TLC, look for the bacterial infection, and you have to give appropriate antibiotics.
Okay, then metallic test. How is it common? Is it common in dengue? I think uh,
It's not
this was the
exactly
question.
metallic taste, but yes, every fever has some altered taste sensation, different taste in the mouth. So that is present in dengue also, but not exactly the metallic taste is something different, which we call, say, after the maternal toxicity or something like that. But in this dengue, we don't have metallic, but yes, there is a taste, different taste, or they say soreness in the throat, in the, this taste is there.
Then what about non-traumatic splenic rupture in dengue?
There are few case reports, but not very common. So
Okay.
they can be there, but not it's not a common manifestation of dengue.
Okay, if platelet is more than 50,000, but the patient is bleeding from any side, should platelet transfusion be given in such scenario?
No, as I explained earlier, we should not give transfusion, but we need to monitor this patient. We should get a repeat platelet count after 24 hours and see if the platelet count is dropping further and if or is there any bleeding manifestation. But at this level, there is no need for getting a count transfusion done. In fact, I tell you, in government setup, when we have a dengue outbreak at 50,000, we are not even admitting the patient. We are so short of bed and so much crowd is there that at 50,000, we ask the patient to go home and observe for the warning signs.
No, but in this case, she has mentioned, it is mentioned that bleeding is there.
If bleeding, sorry, I understood that no bleeding. If bleeding is there, then we need to transfuse. If bleeding is there, then we need to transfuse and we need to admit the patient.
Okay, then how about acute appendicitis due to dengue and its management?
Again, ma'am, acute appendicitis, there have been case reports that acute pancreatitis also not that common. Acute pancreatitis, acute appendicitis, they are present as case reports, and we have to manage that patient accordingly, but there is no common, they are not common manifestations. Splenic rupture, acute appendicitis are not a common manifestations.
But if it happens, what would be the management, I think?
Then we have to treat like acute appendicitis. We might need to even operate the patient. We are giving the platelet count, taking into consideration the platelet count or giving a transfusion. We might need to operate it also. That
Okay. There is one question about reviewing the 17th question of the pre-test. I think that takes us to what is the normal hematocrit?
Actually, ma'am, there's hematocrit is, I was seeing that question, so it is little 42. Generally, we say that it's a varying range, but till in males, we say 38 to 42 or till 44 is normal hematocrit. So that's why the 42 is written. But in females, if it is less than 40, till 42 is normal, above 42 is high hematocrit. So there was some discrepancy in that question. We have written just 42. So
Now I made it 45. I also realized
yeah.
that.
I also made it in
And
the
I
morning.
made it women now. So women have lower normal range.
So that
Okay.
was a misprint. We have overlooked that thing.
Okay, it happens, sometimes. Then splenomegaly, I think you have answered. IV
Splenomegaly is common.
paracetamol.
Splenomegaly, we can see 25 to 30% of patients can have splenomegaly, but splenic rupture is very uncommon. Splenomegaly is there.
Okay, IM injections are not advocated in dengue fever for
Because
what?
there is a risk of low platelets, and if we give IM injections, there can be a hematoma formation at the site. So no IM injections. That is the first line we write in the treatment. No NSAIDs, no IM injections.
What about IV?
IV can be given. IV injections can be given because we are avoiding IM injections because of the hematoma formation. In the muscles, the platelet count is low. As we inject them in the muscles, it can cause hematoma formation. So that's avoided. And IV paracetamol, we can give, like the dose is I think 7.5 milligram per kg, but like if we are dealing with the adults, so we generally give 1 gram. 1 gram IV over 15 minutes. But we have to look for the reaction. There are many times IV paracetamol can cause some serious reactions. So be aware of it. We should be aware of it and look for that.
What is the treatment for leukopenia?
Leukopenia, there is no treatment. As the virus load will decrease, as the disease will settle down, the platelet, this TLC will improve on its own.
I think leukopenia is a sign of, that there is some compromise happening.
Yeah.
Leukocytosis is a sign that the body is trying to fight the infection, and leukopenia is, the body has some compromised on this, and it should, as he says, viremia is decreasing, so then it will recover.
Definitely.
Okay. Sir, in the primary healthcare setting, would it be safe to say that the low platelets in the presence of normal hematocrit, no warning symptoms, is no cause of worry? We regularly see patients panicking with low platelets.
Yes, that's what I was emphasizing, that the patients are worried about the platelets. But what is the low platelets? If suppose the normal report says 1.4 to 4.4 lakhs, and that the report counts at 1.2, the play and it is darkened or bold, so the patient will come to the physician that my platelets are getting low. If it is 1 lakh, the patient, so we have to explain to the patient that this 1 lakh 80,000 all are normal. That's what I was again saying, at 50,000 also without any warning sign, without any bleeding, we are not even admitting the patient. Forget about transfusion. So that is the counseling required. We have to understand, even at 80,000 platelet, it is nothing to worry. There is no warning sign. You can get a repeat platelet count of 24 hours. If it is further dropping, you come to us again. If it is not dropping, it is stable, just relax. So that is more important. Counseling and understanding is more important.
Dr. Piyush, is it correct? Even if it is not dengue, if you do the platelet count in any fever, viral fever,
Yeah,
there would be some decline.
definitely, ma'am. Definitely. That's very
अभी
correct.
डेंगू की वजह से we have become very very particular about this.
This is
Otherwise
because
वैसे भी हो रहा होता है तो पता नहीं चलता है.
This is because in dengue, we are aware of that platelet counts are decreasing, and dengue people are getting investigating. Otherwise, in normal viral infection, normal flu, the patients are not getting the CVC done. But whenever it is being done, we do commonly see low platelet count. But it will not, and then dengue is such a pathology that it will lead to severe decrease in the platelet count. Other viral infection may not lead to such severe decreased platelet count. So that is thing we have to emphasize.
Then there is question about intensivist giving 5% albumin in plasma leakage syndrome.
Not mentioned anywhere, but sometimes we are in a fix and we try to control the volume. But actually, we see there's a lot of permeability. This vessel permeability has increased. That's why the fluid is being lost. So even albumin may not be able to hold that very well. But that's why we say if it is not improving, the shock is severe, think of giving the colloids, Dextran or starch solution. Similarly, sometimes they are using albumin, but not mentioned in the guidelines, not as per the standard guidelines.
What is the indication for FFP in dengue? Intensivist doing PT, APTT in dengue giving FFP.
Yeah, so if
Frozen
sometimes
plasma.
severe dengue, the patient is going into DIC, there the PT, APTT will help it to look for that, and then FFP might be required, but mostly the bleeding is due to the platelet decrease, not the coagulation time is not changing. It's just the clotting time. So you have to just give the platelets. But yes, when the patient is in DIC, severe sepsis, then it might be required to give FFPs and doing the PTA, PTT.
I think this question has come up. You answered this. Dengue platelet transfusion. After how long, how many hours need to do repeat platelet count?
I've already discussed, we can, according to the patient condition, we can repeat after 12 to 24 hours.
Papaya. Otherwise, if the patient was otherwise okay, how often platelet counts to be done?
See, ma'am, if the patient is stable, I don't get it repeated again and again. I will ask to get it after 24, 36 hours. If there is little decrease in the platelet count. Suppose I get a patient who is having mild dengue and the platelet count just he gets it by chance he's having a platelet count of 1 lakh or so. I will ask him that once the fever subsides, you get a repeat platelet count. And if the platelet count is decreasing, then we will manage accordingly. Otherwise, we are not going to just look on your platelet count. So most important is for the warning signs.
I asked this question because in the pre-test, many of them answered as daily. They will do it.
Daily, yes. If the patient is unstable, patient is bleeding, you are having a transfusion, then definitely we will do daily platelet count. That at that time we might need to even do it every 12 hourly. Suppose let's let a case scenario. The patient is having a platelet count of 30,000 today, and yesterday he was having a 50,000. So within 24 hours it has dropped from 50 to 20,000, 30,000, 20,000 drop is there. So I might be worried that the next 12 hours or so it will be less than 10,000. So I will do it after 12 hours here. But suppose the platelet count was 1 lakh and today it is coming as 80,000 after 24 hours. I'm not much worried that from 80,000 it will again go to 10,000 without any bleeding. So here I will repeat after 24 hours.
I think we've all seen, you must have also seen patients with platelet count as low as 5,000. There was no requirement for a platelet and they, recovered from that,
Definitely. That's true, ma'am. But what we do is that if the platelet count is less than 10,000, then we do transfuse at that time, but not before 10,000. So
what is the
very
role
low.
of papaya?
Papaya, ma'am, there is no scientific evidence for it. There have been many trials have been done, but they have no found to any scientific evidence. There are, but some of the pharmaceutical companies have come with a drug also. I think captopril or something like that. They have come with a drug also, which has a papaya extracts, goat milk extract food, and this what is called another fruit is there. But all these have not been found to have any scientific evidence. But yes, another thing, what I do is I will not advocate for these remedial therapies like papaya extract, goat milk, but it has been seen that they don't even have any negative effect. So for the patient satisfaction, I say it does not have any scientific evidence or it will not increase. But if you feel like, you can go with it because it is not going to harm you, but don't arrange it at the cost of selling off your livelihood.
Okay, then there is one personal case here. Here, patient had leukopenia, was pronounced, reached 12,000. Leukopenia, 1,200. No issues in platelet count, and they opted for Caripil and another Ayurvedic syrup. Fifth day, patient had rashes, started Montec LC. All these clinical symptoms subsided, including rash, backache, sore throat. Literature I have checked later, it reduces severity, wondering if the drug can be standard supportive treatment.
No, ma'am, it is not the standard guideline. Again, that's what the capability, that is the name I was wondering. So it is not required, and had the patient not done taken this medicine, still he would have got the same course of the disease. He would have still recovered without this medicine also.
I think we have covered all the questions here. In proven dengue, sometimes positive scrub typhus or results come. How to proceed?
That
If
is already
scrub
discussed. Dr.
typhus,
Mala ma'am have already discussed that thing, that
uh,
such types might be a test may not have been done with the what reliability of the test is there, and sometimes a co-infection can be there. We do agree with that, but not with scrub typhus. Dengue, malaria are quite common, but scrub typhus with dengue is not very common. Here isolation cases.
dengue fever with low platelet but only skin limited bleeding, as petechiae and ecchymosis, but patient is stable. Do they need transfusion?
Okay, that's interesting. That's a little confusing. That has to depend ki what platelet count is having, and if the rashes are increasing and the platelet count is dropping, many a times we do transfuse in these patients. The rashes are increasing and the platelet count is dropping rapidly, we do transfuse.
I think when to discharge the severe dengue cases, you had covered, but you can once again
The patient is afebrile, the shock syndrome, shock symptoms and signs have improved, the perfusion is normal, patient is accepting orally, so and the platelets are on the increasing trend, then we can discharge the patient.
then how to manage high grade fever in dengue?
Already discussed, not recovering, we can think of the IV paracetamol use.
What is this? Is the term saddleback fever still in use?
Not commonly, ma'am. That is for the UG students to learn, but we are not using in practice.
Okay. I think we have covered all. Shelf life of RDP and SDP, how much they raise platelets, time to infuse.
So as I discussed that this single donor platelet is almost 4 to 5 times the RDP, and they can raise the platelet count by almost 20,000 single donor, because otherwise the one bag of platelets, if we transfuse of RDP, then it is raises the increase of platelet count by 5,000. So if we have SDP, it can increase by 20,000. And time to infuse is just, it takes over 30 to 60 minutes we take the transfusion time.
Okay, I think there is one question about manual and CBC by manual method and by autoanalyzer. They
So yes,
differ.
sometimes
How do
we
you
do,
can?
yes, sometimes we do get false reading in the autoanalyzer. So when the platelet count is very low, we should look for the manual counting by Newber's chamber, that should be done.
Then diet for OPD cases.
Normal diet with excessive fluids, and soft homemade diet should be taken with lot of fluids.
If the NS1 positive and Vidal positive, what are the changes in the management of patients?
Again, as I said, ki Vidal positivity, like we are discussing, if the patient is having a history of less than 1 week fever, Vidal test is not indicated in the first week of the fever. And if it is typhoid positive, that may be a false positive with the cross reactivity. And if the patient is having Vidal positive after, say, first week, then fever should have subsided by that time if it was dengue, or we should look for the false positivity. But they can have co-infections also at times, and that to give antibiotics for the enteric fever. Or we will better is to get a culture. We will get a blood culture done. That if that is positive for the typhoid, that will give a more assurance that we are dealing with the enteric fever.
There is another, okay, one more question. A dengue patient breastfeeding mother, can they feed their child as there is risk of transmission?
No, they can feed it.
There was one question in the test about the, what are the dangers of dengue in pregnancy, and what are the most critical parameters to be monitored. One was fetal well-being, and another was they are at more risk of having bleeding. Somebody mentioned, a few people mentioned about they should be on bed rest and all that. Can you just elaborate on that?
That bed rest is not indicated, but as any fever, or whether it is pregnant or non-pregnant, we should have this thing. Rest is required for viral fever, especially in pregnant also, we should have rest, but bed rest was not indicated. So I think that, and otherwise we have to, as we said, that it can have fetal complications also. So we have to look for the fetal well-being. And other thing was that fluid overload. We have to look for the signs of the severe dengue and fluid overload in that female patient.
I think the questions have been answered. Diet for lactating mother, I think other than
Normal diet.
is the same. The patient has to accept this for few days, soft diet, as he already said. Vitamin C, role of vitamin C in dengue patients.
Okay, that is just because there is a lot of many times we just get bleeding gums in that say. So that is why they say ki vitamin C, it's not just not a very significant role, just an antioxidant thing, and it can be taken, but no evidence of using exactly vitamin C in dengue. I remember when I was postgraduate student, we used to commonly write, but then we found there is no literature review for that vitamin C importance in dengue patient. And these days we are not even writing that.
I think we had a marathon question and answer session, and you patiently answered all the questions. I also have to leave. Today was a peculiar day. All of us are sitting in different regions. Dr. Mala was from in Kerala. I am in Kolkata. You are in Delhi. So, but still we found time to get together. I have a flight to catch. So I'll take leave. I think we have answered all the questions. Thank you, Dr. Piyush, for joining
Thank you
us.
for the opportunity.
Yeah.
If I'm not wrong, I think I met you earlier. You were in IBHAS and I was
I-
at a UCLA student, and probably you launched that STG
yes,
book.
yes, yes, yes.
Might be in 2004 or 5 you came to our college, and now I remember that I was trying to wonder where I met you earlier. So
I'll get in touch with you. I'm revising that edition now,
sure,
so
sure.
I will take your inputs on that. Thank you very
Thank you,
much.
ma'am. Thank
So
you, ma'am.
nice to
Thanks for the
connect.
opportunity. It was nice interacting. Thank you, ma'am.
Yes.
Thank you,
Annapurna,
ma'am.
you can close.
Thank you. Yes, ma'am. Yes, ma'am.
Thank you, ma'am.
Thank you, sir. Thank you for your wonderful session. Even we have learned many things which we don't know about the updation of some of the guidelines, and we are very happy. Even the participants are so learned so many things. Even dividing the treatment from the mild dengue fever, moderate, and the even the severe condition of the patients. And from here, I also thank Dr. Mala Chabra ma'am for her wonderful session, and Dr. Sangeeta ma'am for her beautiful session of this dengue fever session. Next month, we are conducting the session on emergency management of ischemic heart disease in primary healthcare facilities on the date of 21st October. Even this session has been recorded, and it will be shared in our quality and patient safety YouTube channel. You can access through this link which is shared in the chat box, and certificate of participation will be given to the participants who are attended pre and post test. And we request all the participants to please provide the feedback form on the session, so that we can improve our session topics, or anything. If you want, you can provide the suggestions in the remarks column also. It is open for the all the participants to provide their suggestions. And we thank Dr. Jain Srivastav sir, advisor QPS division, and also Major General Professor Atul Kotwal sir, ED NHSRC, for his continuous support. I thank all the speakers and participants to make this a second part of this lecture series for make it successful. And we will meet again on the next month of 21st October. Thank you all.